Welcome. This is the early career panel listening party. So we recorded a little over an hour of a early career panel that will eventually be available on the ASRA website for everyone to access. But the point of this listening party is to watch some of these segments together. We'll probably watch about maybe half of it. And then we'll have a discussion about it. And then at the end, we're going to introduce our RAMP mentorship program, which we'll tell you more about. But I'm going to introduce myself, and I'm going to have Dr. Teare introduce herself. So I'm Sisi. I'm in my first year out and attending Hood. It's a pleasure to be with you all. I'm in the Los Angeles area, and I'm excited to host this event with you. So now I'm going to turn over to Dr. Teare to introduce herself.
Hi, everyone. I'm Chelsea. I am currently finishing up just the last couple of days of my regional anesthesia and acute pain medicine fellowship at Cleveland Clinic. I will be staying on at Cleveland Clinic starting in August. So I'm really excited to be here with you guys and facilitate a discussion. So first off, we're going to start by previewing some of the clips from the early career panel that was recorded within the last few weeks. After that, we'll kind of have a discussion. We want to kind of facilitate a discussion about what you guys are taking away from the panel. First off, during the clips while they're playing, feel free to type in some questions into the chat box. We will monitor those and make sure that we are bringing up those discussion topics during the discussion portion. And then kind of will allow you to have some open-ended questions. And then we do have some pre-selected questions if you guys run out of things to ask us and things to bring up. And then towards the end, we'll introduce the RAMP program, which we will talk about later.
All right, welcome everyone. My name is Sisi, and I will be moderating ASRA's early career panel on what we wish we knew before attending Hood. We have an exciting lineup of expert panelists to give you insights on navigating a successful career in both pain medicine and regional anesthesia. This panel will be split into two parts where we interview 3 panelists at a time, but in both parts, we will cover topics in both pain medicine and regional anesthesia. So the objectives of this panel include 1, we're going to help you develop an understanding of long-term career planning and decision-making in both pain medicine and regional anesthesia practice settings. 2, we're going to get into topics for successful transition from fellowship to independent practice and development of clinical services. And 3, each panelist will touch on pitfalls they've identified in their career and how to avoid them in various aspects. So now we'll start with part 1 with panelists Dr. Benjamin Gill, Dr. Lindsay Lewis, and Dr. Gary Schwartz. So panelists, please introduce yourself and mention any disclosures. We will start with Dr. Gill.
Hi, thanks for having me. I'm Benjamin Gill. I grew up in a military family moving throughout the United States and around the world. Into medicine, I taught exercise physiology, kinesiology, and strength and conditioning at a university. I ended up training in physical medicine and rehabilitation. And then my medical journey through training brought me more and more into all aspects of chronic pain management, including a strong clinical and procedural foundation, a lot of research pursuits and teaching. I completed pain medicine fellowship at the University of Utah and the Huntsman Cancer Institute, and I transitioned into private practice after that. I don't have any disclosures for this presentation.
Hello, everyone. Again, thank you for having me as well. I'm Lindsay Lewis. I did my residency training in Philadelphia at Jefferson, and then I went on to do a regional anesthesia and acute pain management fellowship and hospital for special surgery in New York City. And then from there, I moved down to Charlotte, North Carolina, joined a private practice group at a large level 1 trauma center. We are private practice, but we also are hybrid. We do education as well. So I have a unique perspective from that. I work mostly in outpatient surgery and our inpatient acute pain service. I have no disclosures. Thank you.
And I'm Gary Schwartz. I'm an anesthesiologist by trade who trained in interventional pain management at the Mount Sinai Hospital in New York City, a former orphan resident from St. Vincent's Hospital, and then completed my anesthesia training in Maimonides Medical Center. So my career has taken me to a private practice anesthesia hybrid pain group where I was doing almost exclusive pain, interventional pain for a while. And now I'm doing half regional anesthesia, half pain, half management for AABP LLP, where I'm on the executive committee and a partner, which gives it a unique perspective. We provide anesthesia services at a hospital with a residency. We have a private practice interventional pain practice, and we cover multiple outpatient ambulatory surgery centers and plastic surgery offices. And I guess I'm getting a little bit old in the group over here. I do have disclosures and that I'm an ad hoc consultant for Teare Biosciences, and I have stock options for Comure Health, but I will disclose or discuss nothing in this talk.
So first, we're going to get into topics pertaining to a career in pain medicine. So first question, this is for Dr. Schwartz. How should we think about navigating our career? What should we be thinking about at years 1, 3, and 5?
So I believe in years 1 and 3, especially, more importantly for year 1, is just to get your feet wet. And a good mentor in a society like ASRA, you want to become an expert in doing your interventional procedures, because the pain management fellowship, interventional fellowship, is really only 9 months between your vacations, your outside rotations, whether it be anesthesia, physiatry, and different sort of aspects, neurology, radiology. You really only have 9 months of fellowship where you're learning all these procedures. So your first and second year out of fellowship is just to become an expert in doing your interventional procedures, learning when to do the correct procedure on the correct patient, or when knowing to say no, you are not an interventional candidate. Building your reputation both locally, whether it be for your private group or hospital, and nationally for different societies, and just find a mentor to lean on to discuss how you want to practice in the future. I think that's the most important. And then from year 3 and 5, just see, where do you want your career? Do you want to be an owner of an ASC? Do you want to be part of a multi-specialty group? Do you want to be a solo practitioner out and hang a shingle in a different city? And then you determine where you want to go from there. That's my expert opinion on this.
Great, thank you so much, Dr. Schwartz. So the next topic, let's get into referrals or marketing. We all know this is a very important part of private practice. So this question goes to both Dr. Gill and Dr. Schwartz. What are some pitfalls to avoid, and what can we do to prevent them?
Well, Dr. Schwartz already kind of touched on this with the year 1 to 3 discussion. I'd say the number one pitfall that I bring up with mentees and other individuals is you're not known. You're not introducing yourself to others. You have to be able to express what value you bring to patients. And I'd say there's a few different spheres of marketing and referrals, or however you want to look at it, that you need to be covering. Number one is within your group, whether that's a single specialty group, maybe you're all outpatient interventional pain management, you need to have a role within that and have that defined, be able to speak to that and market to that. Within the institution, whether you're in a hospital practice or maybe an academic center, you need to be able to market and say, how do you fit in within that sphere? And then to patients and to other providers outside of the group or institution, right? So in all those spheres, you need to be known. You need to introduce yourself to others. And then I think the second biggest pitfall that I see is not closing the loop and continuing to collaborate. So let's say I get a referral from a surgeon or from another maybe primary care doc. I need to be able to send them back a message and say, I saw that patient, this is what we're doing. They need to know that that referral is appreciated. They need to then understand better how you fit within their ecosystem of patient care. And so between
all right, so this is where I'm going to fast forward a little bit. So we're going to move on to another section here. 14.5.
Speak to as far as with current fellows, and they're trying to go out into private practice or in another situation and say, well, how do I actually do this? Take time to actually read the LCD requirements. Those are local coverage determination. Local coverage determination factors are on the Medicare website. You can look up any procedure that we do. Some of them are very detailed. Some of them are a little bit more vague. One example, very detailed, is I would say sacroiliac joint injection. and there's a list numbered out saying that you have to fulfill this, and this to proceed with sacroiliac joint injection. If your notes are reflecting what's listed in that LCD, you should be very successful. And by the way, most of the commercial insurance carriers will be pretty similar to that. You might find some variants depending on the state or the area that you're at. But if you can take what is written there, kind of the law, and put that same thing in your note, maybe in a template form or something else, saying that the patient has done this much conservative care, therapy, chiropractic care, they've had pain for this amount of time, they've done these other treatments, that is why I'm proceeding with this treatment, then you should be more successful getting it authorized if needed, and number two, getting it paid for and not having risks of an audit down the line. So that's the biggest thing is that I would say is making sure you're doing the right things to get the patient the care they need. As far as resources associated with that, you know, ASRA's got several things. Just earlier, I was refreshing my memory. I've looked at on the website several times. There's a whole section on the ASRA website about business courses that you can link to. Going back a number of years, I've participated in some webinars that talk about billing and coding and how to do collections and so forth. And I say just another tip, if you need something more advanced, that's why you link up with mentors. One example of that is maybe you're in an area that you say, I'm not getting paid very much for doing radiofrequency ablations, maybe at an ASC or in the office, whatever it is. Or maybe it's with just specific insurance carriers. And you say, why is there such a discrepancy? This insurance is paying this much, this one's paying that much. How is that actually occurring? Well, some mentors out there could actually help you sit down and negotiate with that specific insurance carrier to increase that reimbursement amount, which
All right, so this we're gonna fast forward a little bit more. We're gonna move on to the question about what would you have done differently in fellowship. So
fellowship, you have a job lined up, you know what the details of that job entail, and you know how you're going to get paid or what the demands are for you as well. Okay, so that could be a collections, it could be a billings model, it could be a work review model, one of those things. And within that, you actually have to have an appreciation for what type of work will it take to produce that result. So one of the things that I did is I sat down with our department chair, who was fantastic, and he provided in somewhat an anonymized fashion, here's 8 different attendings, and knowing to a good degree what their practices looked like, we could then compare how much they were actually collecting in work reviews or in dollar amounts. That was super insightful. And you started to recognize, you know, many individuals are going to go out and do some sort of mixed practice. And that could be a mix of interventional pain and regional anesthesia, or it could be doing general anesthesia and pain, or rehab and pain. Many different sorts of combinations, or even starting an online business on the side and doing some clinic. Whatever it is, understanding for what does it take to go from, you know, 2 clinic days a week to 3 clinic days a week? How is that changing your procedural output, your work RVUs, your dollar amounts? Starting to understand what your time is actually worth. And, you know, we mentioned before, is it worth it for you to be doing certain procedures? You know, sometimes there's an argument to be made, is this the right thing for the patient? Is this the right location for you and the patient to be accomplishing this, to do that procedure? Or do you need to change the model a little bit?
okay, now we're gonna fast forward a little bit more. We're gonna get into the regional anesthesia. This is the regional anesthesia section, and the question is how to navigate your career and what to think about for years 1, 3, and 5.
So, Dr. Lewis, how would you, suggest to navigate a career early on? What should we be thinking about for years 1, 3, and 5?
Yeah, you know, I think there's a lot of commonalities regardless of your subspecialty with, you know, pain medicine or regional anesthesia. So I'll echo a couple of points already that have been made. But I think, you know, first and foremost, whatever practice you join, identify somebody or a couple of people within that practice that you trust to ask clinical questions to. Regardless of how great your training is, you're going to come across things you've never seen before or some iteration of it. And, you know, you're coming from an environment where you always had people around you and attending or other co-fellows or co-residents to ask questions to. And now you're in an environment where you're supposed to just do it on your own. And so having colleagues that you trust to give honest feedback of, hey, have you ever seen this rare scenario before? Or You know, like it was mentioned before, I now have a complication. How would you handle this? Or what's the good follow-up? So identifying that early, I think will really help in your career. So I would say that's primary, number one, for year one. And then as you move through, you know, those first couple years, I would recommend being a sponge. So see how things are done. It's probably there are definite differences from where you came from and in your training. It doesn't necessarily mean that the differences are bad. And I think, you know, at the very first onset in those first couple of months, you may say, oh, wow, we did things a lot different where I came from. I want to go ahead and change that. But I think if you give it time and watch and see, maybe not all of the differences need to be fixed. Sometimes it's different structure, different support. Maybe this is now a private practice. You came from academics, or you're at an ASC with less resources. So I think if you jump in and try to make changes really quickly, you may spin your wheels and waste your energy. But so take some time and really see the structure that you're working in, and then come in and try to implement changes. So I really think those first couple of years, not that you can't make suggestions, of course you should, and especially if you think there's opportunities for improvement in patient care, but I think be more of a sponge in identifying the difference in structure. And then those next couple of years, year 3 through 5, really go for it and try to change things that you think are able to be changed in your environment. And then I'm just going to echo the importance of mentorship. I think it is so important to have great mentors, and I think it's important to have great mentors within your institution, but then also outside of your institution at other facilities that are similar to the one that you're in. So like I mentioned, I'm in a private practice, but we have an academic arm, and that's pretty unique to be a hybrid practice. But finding, you know, mentors in other hybrid practices has been really helpful. And so I think those first couple of years, just identify those mentors and really lean on them when you need some support.
Great, thank you, Doctor. Okay, next question for both Dr. Lewis and Dr. Schwartz. What should we consider before introducing new blocks into a regional service?
So I'll start. You know, I think anytime you're going to change something into a regional service, just really think about, you know, can you continue this for the entire group? So let's say you have an acute pain service of 10 physicians. And if it's a new block that is just starting to come into practice, does everybody know how to do that block, or feel comfortable doing that block, or even want to do that block for a change? So for example, you know, total hip arthroplasty, are people still doing femoral blocks, fascial iliaca blocks, pangs? And if you're going to introduce something different, make sure that there's a consensus, because I do think that it's important for surgeons and other stakeholders within your acute pain service to have continuity and know what to expect. So I think it's important, not that you need to always do the same block and everyone needs to, you know, come to some unity, but I do think it's important that if you're going to change or introduce a new block, that at least you have buy-in from your members. Because otherwise it may lead to some confusion amongst the other stakeholders, specifically the surgeons, if there's different blocks being done. And they may feel like, oh, well, this one didn't work because patient's moving their leg. Well, the new block's motor sparing. And so just trying to think about that. And maybe it's an in-service for your fellow members, or just a meeting to talk about the benefits, the pros, the cons, those sort of things. So I would just think of, can you expand this more than just you changing that? And can the entire group get on board?
That was a great answer. And I want to add to that, especially with the staffing. It's great if Dr. Lewis, the world expert, can do 100 different blocks, but she wants to take vacation. So if I'm managing a practice and I cover a couple of ASCs, we have to give the same clinical care to the same surgeons and the same patients all the time. Another important factor is the why. Why are we switching? So I started off my career peripheral nerves, stimulators, then we went to ultrasound, from the days of femoral nerve catheters with the CPM machine in the hospital for 5 days, which were like torture devices, to, okay, why are we offering adductor canal blocks? The femoral gives great pain relief because you want to send your patients home. So we have a motor sparing block that's going to allow you to do this, to bring your cases to the ASC. Okay, I might want to offer something for the posterior knee. This is why I'm doing it. This is why it's safe. let them know the potential complications just in case you or your colleague might have one. And then you can make sure everyone is on board. You can't be like, oh, Dr. Lewis taught me this block last weekend. I'm going to mosey into the OR and do it. And then, God forbid, you have a complication. It's going to end that program. So you want to get everyone on board. The surgeons, the nurses, the recovery room nurses, OR staff, to make sure, okay, this is what we have. Again, same thing as the pain. This is the issue we have. This is our solution to improve our patient care, improve PACU throughput, improve patient satisfaction, pain relief. This is what we're going to do. By the way, look out for these potential complications. Find the champion surgeon or a champion group. Let's get this started. Make sure you have backstaffing of your team too. So if Dr. Lewis wants to hang out in the Caribbean or jump out of a helicopter and go skiing, he could do any of those things and everyone gets the same care.
All right, and now we're going to move on to part 2.
So panelists, please introduce yourselves and mention any disclosures. We will start with Dr. Anderson.
Hi, I'm Melody Anderson. I'm the Director of Regional Anesthesia at Carolinas Medical Center in Charlotte, North Carolina, and I have no disclosures.
Hi, everyone. I'm Joseph Liao. I work at Stanford. I have no disclosures. I specialize in neuromodulation and invasive spine interventions.
Hey guys, I'm Keelan Williams. I just graduated from Stanford Pain about a year ago, Pain Fellowship. I have no disclosures. I work in private practice in Brooklyn, living in New York City.
Okay, and then we're going to fast forward to a section where they talked about red flags in during job interviews and contract negotiations.
So yeah, I was an expert in contracts, so I'll leave that one to him. Interviews, so mine, I'm pretty recent, like in the last year. I would say red flags that kind of stood out to me that I learned along the trail was someone who's trying to offer you the job without meeting you, without having you do a site visit. That's also kind of suspicious. If they're not being completely honest about, how much med comp they're doing, their opioid prescribing, and their overall kind of practice management, that was kind of suspicious. I really enjoyed when future employers kind of gave me statistics. So I've had patients, not patients, but I've had future employers kind of give me like, we have these patients, this percent are on opioids. They range from this age to this age, and this is their plan. Because I know that opioids are a really sensitive subject right now for a lot of practices. Some of them don't do them at all. Some of them do them maybe a little bit too much. And I think that the key is finding that middle ground. And I think finding that middle ground just comes with transparency. So employers that aren't going to be transparent with you, probably you should scrutinize a little bit more heavily than the ones that are kind of just telling you how it is. And I kind of use transparency across all fields when it comes to, income, earning potential, leadership potential, partnership track. Just ask specific questions. And they don't have to be really deep questions. Pretty much one thing that I asked was, if I start now, what does a partnership track look like? What is the trajectory? And some employers would be like kind of wishy-washy and kind of give me generics. And then I would have other ones that would say 1 year this, 5 years this is the buy-in, the X amount of money, but it was very specific. So that's the two things that I would look for as green flags, is transparency and consistency in what they say. Otherwise, red flags, that's about it from what I could kind of glean from. Oh, another thing is looking back at their kind of malpractice history. Are they currently in any cases right now? Is there anything pending against them? And what's the physician turnover? So how many people have left in the last 3 years? How many people have stayed for 10 years? Their retention rates, things of that nature. And you want to make sure that you look at the retention rates across the employees as well, not just the physicians. Because I've had some practices that I've run into where the staff is changing every day, the MAs are changing, the techs are changing, and that's going to impact your workflow significantly if you have to kind of change or reteach someone every 6 months. And one thing, kind of going back in retrospect, is asking specifically about what they have available to you. Like what needles are they using? Like how old is their fluoroscopy machine? How frequently do they have it checked? and specifically who operates it. Do they have an MA operating it, or do they have an actual technologist operating it? That's really going to affect your day to day, and just keeping all that in mind. And so I think kind of going into any interview, just think about your day now as you are as a fellow, and what are some of the things that are roadblocks to your success, whether it be tiny logistical things or like overarching issues that you have, and see if you can ask those questions about your employer to see if you can kind of see how you can envision yourself in that practice going forward.
I think those are great points, Dr. Williams. Some other things I would also add. One thing that Dr. Williams mentioned earlier that's really important is to really vet out the owner of the practice. But in addition to that, you also want to make sure that there are no lawsuits or complaints filed against the other associates in the practice. Because certainly if you're having some internal referrals to one another, you may potentially be lumped into things down the road if you're part of the same practice. So I think practice with a reasonable track record without red flags from that perspective can certainly make your first job a lot less challenging to get integrated into. The other part is to really understand how the sausage is made. You know, understand where patients show up. Track each segment of the patient experience. Meaning, how do they get in for a referral? How do they get checked in? How long does it take for them to be able to see you? And what is the aftercare like for basic injections and basic follow-ups? These are all things that are really going to impact your ability to thrive as a clinician in your practice. Because if a practice is well ran, they'll know every segment of that process. Practices that tend to be more disorganized tend not to know about every segment of their practice, because a really great owner would treat their practice like it's their baby. So like your own babies, if you love your baby, you're going to know everything about that baby. And I think that that's highly important. And the other part is to also know where the referrals are coming from, because by knowing where the referrals are coming from, you'll have a better idea of the type of practice that you're doing. So if your practice is primarily a workers' comp or personal injury, you may want to also see what type of lawyers are actually making those referrals, because depending on the types of cases that they send you, that may actually impact your level of comfort with the types of care that's being facilitated.
Dr. Lara, can you speak more on contract negotiations?
Sure. So for contract negotiations, the key is to really understand what the market rate is in that region. And that's where your network is really important. For every job that in an area that you're not familiar with, I would actually recommend reaching out to people that you know online, or maybe through word of mouth through the reps, so that they can get you plugged in with the reps in that region where they know the primary players in that area. And based off of that, you can actually ask questions about what the compensation is like and what the practice will look like. And this is really important because if you're in a highly desirable major metropolitan area, your room for negotiation may be very different than if you're somewhere that's less desirable in a flyover state. And so because of that, you really want to know what the standard is in that area so that you have a point of reference. The reality is that most people during the first 12 months of practice, they will likely break even, or they may make a little bit less than how much they're actually getting paid. But you do have to realize that it's a long-term game that you're looking at when you're looking for job opportunities. So with that, you really want to see what the projection will look like. And based off your projection and how quickly you think you can get up to speed, that will actually impact your contract negotiations. So for example, if you're in a large hospital-based system, for the most part, your RVU base or your salary base, you're going to be trying to negotiate for a higher base and a higher rate per RVU, because those are the things that are a little bit more malleable. And that way, no matter how inefficient a system is, you can at least have that guaranteed base to fall back on. Now, in private practice, different. In practices in which there's a lot of opportunity for growth, that it may make more sense to try to go for something that's more production-based. And to go down that route, you really want to make sure that you understand what the reimbursements are like in that region. And that's all important because ultimately that allows you to figure out what the most important parts of the contract negotiations should be. So in general, the things that are always negotiable are the base salaries and also the bonus model. Some of the more established practices probably won't be as flexible with that, but most practices have some wiggle room on that. Other things you can negotiate for would be things like sign-on bonuses, relocation stipends. In addition to that, some other things you can consider would be things like tail coverage. So if you leave a practice, typically you would have to pay for the malpractice insurance on the back end in case there's litigation that comes thereafter. So because that, those are some things that you can try to negotiate with independent practice. Now, when it comes to larger hospital systems and academia, it might be a little bit more challenging to negotiate numbers. But that being said, you can totally negotiate for other things, like this is the type of cases I want to see. These are the days in which I want to operate. This is how much block time I want to have. You know, everything is up for negotiation. You just have to be strategic about it. And one final point about negotiation is that you can't expect to win everything. Have a list of things that you want to discuss and internally really understand which ones are most important to you and stick to your guns for the ones that are important to you. And then for the ones that are less important, at least you can let the other party feel like they want something throughout the negotiation.
All right, and now we're gonna forward to another section. This will be the last question for the pain medicine section. So it's gonna be right here. What would you done differently in your last few months of pain medicine fellowship?
Because I mean, it's a long year, it's a busy year, and you're in your last few months. You probably have taken boards, you have your job lined up. So it's really easy just to be like, I'm gonna have a little bit of like lax time. But that's when you really have to start ramping it up. And one thing that I was really grateful I did was I did everything differently. I got comfortable with using these needles, specific techniques, But then I just started saying like, let's do everything differently, and I experienced everything under the sun. Because by about 6 months, you kind of know how to do everything pretty well. And so at this point, you should be pretty efficient and kind of getting more proficient in your procedures. But what you really want is that clinical diversity. So asking your attending, hey, how do you do it? Or what's a new technique? Can we use these needles? Can we use this AP or oblique approach to approach this problem? And then thinking about it more that way, because when you're on your own, you're not going to have that person kind of in the corner kind of directing you. So knowing how to approach one problem 20 different ways is really going to help you when you're in independent practice. So that's one thing, just mixing it up, mixing up your technique, breaking away from being comfortable and really challenging yourself when it comes to your procedures. Kind of piggybacking off that, also working on, the speed while being safe. You're not going to be a rock star towards the end, but kind of just always keeping in mind that things can be a little bit more efficient. You could use a little bit more fluoro. You can use a little bit less imaging and kind of keeping things along, especially if you're going to be in like a high volume academic or private practice setting, because efficiency in everybody's day is really important. And then I think it's about gaining contacts. So if you're not going to stay in your region of like where your fellowship is, like for me, I did fellowship in Stanford, and so by about month 6 and 7, I was already reaching out to my reps in California to get contacts for New York City, setting up dates, setting up dinners, just to kind of be introduced into the new environment right away. Because no one's going to reach out to you necessarily. You really have to make the effort to make those connections, and kind of having some things set up. And then towards the end of fellowship, I guess if you've already taken everything, boards and everything are all good, and you're still trying to just learn new things, keep reading, keep learning, enjoy your time while you have it. I will say take a vacation if you can towards the end, because once you start, it's going to be a pretty uphill climb for about 6 to 8 months. And that's about it. The biggest thing is just really starting to really challenge yourself and really try to mix things up and learn everything you can and trying to squeeze it all into that last few months while you have all of this foundational knowledge already set.
Great, thank you, Dr. Williams. All right, so now we'll discuss topics pertaining to a career in regional anesthesia and acute pain with Dr. Anderson. So Dr. Anderson, let's talk about how we should think about navigating our career. What should we be thinking about for years 1, 3, and 5?
So for year one, I would say in my own experience, focusing on becoming clinically excellent is a good place to start. So what I did my regional anesthesia acute pain fellowship at Mass Gen, and there I learned beyond the basic bread and butter blocks foundation into doing, advanced fascial plane blocks and catheters, paravertebrals. How do you, usually when you're looking for a nerve, it's usually by a blood vessel. What do you do if it's a vascular path and there's just no vessel there? Like, how do you find it? So at that, I really strengthened my understanding and skill in regional anesthesia. And then I would say going back to year one, becoming efficient clinically and learning how to do things quickly and learning how to use your clinical judgment to when you have that patient in front of you, and really just having confidence in yourself. Understand, I know sometimes the culture in medicine in the United States, the anesthesiologist can sometimes be seen as a service to the surgeon, but sometimes the surgeon's making the anesthesia decisions. And so really by the end of year one, you don't want to be asking your surgeon, do you want a block? Because you are the anesthesia expert. The question is, you've looked at this patient for XYZ reasons, you feel a block would be beneficial and you'd like to offer one. Do they have any surgical concerns about a block? And that's the confidence you want to have. Start if you're great at it by the end of year one, but definitely by end of year 3 or 5. By year 3, you're clinically much more experienced than you were at year 1. And so you want to just develop that, find your own niche, like what can you do outside of just beyond placing blocks that's going to help you grow as a person and help your department. And so that's what I would do year 3. And then year 5, especially if you're looking at building an acute pain service. So some background, I work at a level 1 trauma hospital for a good while until 10 years ago and before, we did no regional anesthesia at all. And now we do about 350 blocks a month. And that's something that as a year 5 physician, you're going to have the skill, the background, and then the connections to make that happen.
Great, thank you, Dr. Anderson. So next, looking back, what helped you think about starting an acute pain service in an interdepartmental POCUS regional anesthesia partnership?
So Charlotte's my home. And for me, it wasn't a question of, do I want to do academics or do I want to do private practice? It was just, my whole family's here. I want to come back to Charlotte. And so when I got here, I noticed that, we were starting to dabble in blocks here and there, but there wasn't much consistency. And you'll find with surgeons, even if you can do the most amazing block, if they can't get that consistently, they just want to know what they're going to get. Otherwise, they'd rather do a field infiltration by themselves, because even though it's not as good, they know, like, okay, at least I know exactly what my patient's going to get. So it was a bit spotty. And, what we did is we developed just a small group that did blocks, all the perioperative blocks and consult blocks. And from that, relationships grew and it just snowballed from there. The surgeons could see, surgeon A, all of his patients are getting blocks and leaving sooner and using less opioids and have higher patient satisfaction scores. Whereas patient B, with surgeon B, maybe they're not. So then surgeon B wants our services, and it just grew from there. So that's how the acute pain service grew. And then POCUS is really interesting. So I went to the ASRA POCUS course back in, must have been 2021. And it's a fantastic course. I can't recommend it. It's one of the most useful courses I've ever taken. so useful in trauma when you have a patient that becomes acutely hypoxic or hypotensive and you don't know exactly why, but you have an ultrasound there anyway, and it gives you so many answers to so many questions that you might have. So I took that course, and then when I came back, I connected with Dr. Denise Fraga. She is the Emergency Medicine Ultrasound Fellowship Director at CMC Maine, and they actually have a very robust point of care ultrasound program. They were pioneers in it, doing it in the 90s before other emergency medicine programs. So it was right under like my feet all the time, but I had no idea. So Denise and I formed a collaboration where she and her ultrasound fellowship trained colleagues will teach us point of care ultrasound. And in turn, we teach them regional anesthesia blocks for common acute pain conditions encountered in the ED, like hip fractures, rib fractures, things like that. Because I mean, I'm only one person. We don't have a residency, and I can't be there at all hours to block every single patient. And so I'm really grateful that they're able to offer that robust service for in our emergency medicine department. And I have certainly benefited from their POCUS knowledge. I use it every single day.
All right, so we're gonna pause here. So here you kind of got like a snippet of these of the early career panel, and again, like the full recording will be on the ASRA website for you to preview the rest. So now we're gonna move on into the discussion. So I'm gonna switch my screen share here, and we actually have two of our panelists here with us. We have Dr. Lindsay Lewis and Dr. Melanie Anderson joining us. So thank you guys for being here.
All right. So I didn't see any questions come into the chat, but I would like to open it up to all of the listeners. What are your takeaways from that? What are some points that really struck a chord with you? What are your thoughts after watching some of those clips? From my standpoint, when I was watching this for the first time, I think some of the things that really resonated with me were, some of the things that we don't really learn in residency or fellowship, like contract negotiations. How does billing work? What are some red flags to look at with residency or with job interviews? Because those are some things that, aren't routinely taught in our curricula. So I thought that was really interesting to hear some takes from some of these early career physicians. Some of the other things that I thought were touched on again and again were the importance of mentorship, which is a great kind of lead into the mentorship program that we'll be discussing shortly. But I would love to hear from you guys what your main takeaways from those clips were.
Yeah, I thought I really liked Gary Schwartz's point on consistency with regional anesthesia, and that you have to offer them a consistent product. In some ways, I don't want to say it's like the surgeon is your customer, but that they kind of are. Like it's a two-way street. You work together to come up with a plan for what's best for the patient, but you want to make sure that like you have consistency so that your service can thrive and it's reliable and it's something that they can count on whether it's Wednesday at 6 a.m. or Friday at 3:30 p.m. They kind of know they're going to get about the same product. So I really liked that point that he made. Also, shout out to Lindsay Lewis. She's we work at the same practice. She's over at our one-day surgery center and then rotates with us on the acute pain service. So nice job, Lindsay.
Yeah, I will say when I was watching these clips, one thing that you said, Dr. Anderson, that hit home with me was, not asking the surgeons, do you want to block? Because we do that all the time. And the question should be, do you have any concerns with a block? So that way you can bring your expertise as a true consultant rather than, asking the surgeons what they want. I thought that was really cool. On another note, when Dr. Schwartz and Dr. Lewis mentioned how to introduce a new block to the service, we actually have a newer attending on our acute pain service who came in and he was asking, can I do a fascia iliaca block for this hip? And we don't usually do those. We usually do either a fascia iliaca or a PANG for a rescue block. We don't usually do them preemptively just because that has been the culture there. And he said, you know what? I've had a lot of really good success in my previous institutions with this block. I'm going to ask the surgeon. I'm going to see if they're interested in this. And the surgeon did say yes, which was a very nice surprise. Sometimes they don't always have buy-in right away. But now I'm wondering if we can use your advice from all three of you when you mentioned, make the consistency happen. So now that this attending was able to do this block, let's see how the patient did. Let's see, let's follow up on them. Let's offer this to more patients, and maybe that can become a more consistent part of our practice. So I really took your all of your advice when I was watching these clips and kind of saw it in action today, which was pretty cool.
And Chelsea, when it comes to blocks for hip fractures, give the orthopedic surgeons their own data. So in their own AAOS guidelines for fragility fractures, regional anesthesia is recommended with strong grade A evidence. And you can show them this is the paper, this is your people. My people say this too, but this is your people. And just kind of, ease them into it, make it their idea. But, and there's really, if you have an elderly patient with a hip fracture and you're offering what's best patient care, what's evidence-based care, I don't really see an argument where that is, unless it's some blatant contraindication to a block as to why you wouldn't do one. Yeah, so I would almost wish I had a printout of that, but you could look it up, Google it, save it. I have a copy saved on my laptop to send out when needed. Yeah.
Absolutely. Sorry, my dog's barking, but absolutely. I love that advice. Thank you so much.
Yeah, I think I'll just kind of echo what you were saying, Chelsea. Sometimes it's great when you have new people coming onto the service because they want to push the limit a little bit, I would say. But I think sometimes we write off surgeons when we ask them, repeatedly, this patient would benefit from a block, and then they say no. We kind of, for lack of a better word, give up on them. And then you have someone new join the service and they are kind of like, well, that's silly that we aren't doing blocks for these patients. And then they ask again, and it's been a year or 2 years, and the surgeon's like, okay, I'll try it. So I think just to kind of put that out there of, especially if you have a patient that you think will really benefit for a particular reason, to just keep trying and to keep advocating for the patients, and you'll get a lot more success that way.
Also, evidence-based conversations. When I go into a conversation with a surgeon, I'm never, you will never hear the words, do you want to block, come out of my mouth. I ask if they have any surgical concerns, and it's a discussion. And then, I don't want to block is not that's not a reason to not do a block. So evidence-based, know what, the studies show, from an anesthesia and, their perspective too. For instance, I was sitting in a case, this was, probably a month ago, and it was a laparoscopic partial nephrectomy. And the patient, who'd had no medical background whatsoever, she said, I want a quadratus lumborum block. And I'm thinking she works in healthcare or something, but she didn't. A friend told her to ask that. So I'm like, okay. And so I went ahead and I talked to the surgeon. I said, the patient requests this. I'm happy to do it. So placed it, and then they start working laparoscopically, and you can actually see the QL psoas muscles laparoscopically with this approach right by the kidney. And he was like, what's this fluid? And I'm like, no, that's my block. Don't suction that out. That's my block. But it kind of it opens up a discussion of actually, if you're there, could you just place local there? And you're thinking of ideas like that and things like that, and really developing a relationship with your surgeons.
Yeah, that's great advice. I really love that. Okay, does anybody else have anything that they want to touch on? I want to make sure that we have enough time to introduce the mentorship program, but any last thoughts from anybody?
There's a question in the chat that just popped up.
Yeah, that's definitely a good thought. So it's from Jonathan. Sorry if I mispronounced that. But wanted to emphasize that when Dr. Lau said it's very important to research if there are any malpractice lawsuits against the physicians and employees in a certain company, since that could possibly stir up something bad just by being involved in that company. And again, that is something that I probably never would have thought of when exploring job opportunities. So that definitely is something that is very real and very important to consider, and probably something that we aren't routinely taught during training. So I definitely agree. That's extremely important. Okay, well, Sisi, if there's not anything else that you want to touch on, I wonder if it's a good time to move on.
Yeah, we'll move on to talking about the RAMP program with the last few minutes we have remaining here. So RAMP stands for Regional Anesthesia and Multidisciplinary Pain. And this is the name we came up for our early career mentorship program. So it's for both pain medicine and regional anesthesia. So what this is a mentorship pod program for those in their first 3 years of practice. And so this mentorship pod is going to consist of mentees at different stages in their career, plus a mentor who are at least at a mid-level of their career. And these small groups will be led by mentors with expertise in practice management and focus on early career development. And there will be discussions on resources and any other topics related to building a success in their early career. And again, we're going to try to do our best to match people into groups based on either region. Of course, will be based on whether you're in regional anesthesia or in pain medicine. So let Dr. Teare take over mentor roles and responsibilities.
So for the mentors, they will be responsible for leading virtual quarterly meetings with their mentees with discussion topics related to practice management and early career success. Groups will provide mentorship and advice throughout the early career, and the mentors will be responsive and committed to the program and assist mentees as needed. So for the mentees, their goals are to foster mentor and peer relationships by offering meeting topics or issues that they want to discuss. They'll participate in virtual quarterly meetings with their peers and with the mentor within their pod. And they will maintain an active ASRA Pain Medicine membership. So in order to enroll, enrollment is now open. There are no registration fees. We do have sign-up forms to help us kind of set up successful matches between mentors and mentees. So there are various questions throughout the form that can help kind of match us up with good fits in your pods. And initial group formation is expected around July 2025, so as early as next month with rolling enrollment.
Thank you, Dr. Teare. So here are the sign-up forms, and there are QR codes. So if there's a specific sign-up form for mentors and a specific one for mentees. And we will also be sending these out in the ASRA newsletter as well. So if you don't manage to capture this today, you should be getting an email about it. But feel free to take a screenshot and start filling out the form if you would like to sign up today. And the point of this, again, is to mainly support those in their early career, so in their first 3 years of practice. This is specifically different than ASRA's mentor match program that's one-on-one mentor match, one-on-one with mentors and mentees. This is, again, like a small group so that we can build a community and people can share with each other what they're dealing with at different stages so that there can be this more like bi-directional mentorship. If anyone have any questions before we wrap up here about the RAMP program, feel free to unmute yourself and ask any questions that you may have. Okay, if no one has any questions, I expect everyone to be signing up today, scanning that QR code, signing up. We would love to see this be a really powerful way to build community for our early careers. These are the people we feel like need the most resources and support. And so we love to support them in that. being that ASRA Pain Medicine is such a great society and supporting people every stage of their career. And so we want to continue creating more robust programs to help people along the way. So please take advantage of this program, sign up either to be a mentee or a mentor, and we'll put you in your respective pods. And thank you all for joining us. This has been a great listening party. Thank you, Dr. Teare, for co-moderating with me. And thank you to our panelists, Dr. Anderson and Dr. Lewis, for joining us today and participating in the discussion. Hope you all have a great rest of your night.
Thank you all so much.